Um, I got an email a few days ago about, my title was Ecmo deployment and did I want to change it? And I spent a few days trying to think of a better title, but it's hard to really jazz up technology that has essentially remained unchanged since John Gibbon used the heart-lung machine in 1956. So I just left it at Ecmo. So during this talk, I'd like to talk a little bit about the definition of Ecmo. We'll talk about the indications and contraindications, results, which will be quick, complications, and then talk a little bit about our adult Ecmo deployment protocol and sort of where we'd like to go with the Ecmo program here at Duke. Two things to remember. Ecmo should always be considered for patients in cardiogenic shock. It is not necessarily the first thing you should think of, but in all patients in cardiogenic shock, should be something that you think of. And as it says down at the bottom, we're always here and we love to hear from you. So we love to hear earlier rather than later. It is important, though. Time in these patients means their end organ function, and patients who have lost end organ function have no options in terms of advanced heart failure therapies. So Ecmo essentially is a system that draws the blood out of the venous side of the system. There's gas exchange, both oxygenation and ventilation essentially, and then it's delivered back, either back to the venous side or to the arterial side. There are three essential components: vascular access cannulas, and again, we can either cannulate people peripherally, generally percutaneously. We don't do a whole lot of cut downs here. We have to cut down to remove the cannulas. Our cannulation strategy of choice usually is the right common femoral vein and the left common femoral artery. We also, as one case pointed out, we use the axillary artery. When we talk about veno-venous Ecmo, there are single cannulas and dual cannulas. The membrane oxygenator can be of two types. There's the silicone membrane oxygenator, and then there are hollow fiber oxygenators, and then a pump. And it's a relatively simple setup. You can have additional things like a bridge, which is a connection between the venous and the arterial limb of the circuit, which can be used for different things. A heat exchanger, which we use sometimes to cool the patients or warm the patients, depending on their problems. And then there's additional access depending on how the circuit is set up, either for CVHD or plasmapheresis, or in case things like trauma, you can give massive volume resuscitation. There are two types or two configurations for Ecmo. There's veno-venous and veno-arterial. Veno-venous is for gas exchange only for primary pulmonary failure, and then veno-arterial is for gas exchange and systemic perfusion if there is also cardiogenic compromise. This is a diagram of veno-venous, or two diagrams. This is essentially the older way we used to cannulate. Dual cannulation, you put a cannula in the right common femoral vein, which extends up to the junction of the SVC in the right atrium. Draws the blood out, goes to the pump, to the oxygenator, and back through a right internal jugular cannula. If you see these, the placement of these cannulas has to be relatively precise. If they're too close, then you'll get recirculation, and the blood that should be going to the system goes straight back out the cannula. If you put them too far, or if you don't insert them far enough, then you won't actually have enough drainage to actually oxygenate the blood. The newer single cannulation is a dual lumen right internal jugular cannula. In the adults, we call it the Avalon cannula. This has dual lumens. It draws the blood both from the SVC and the IVC, sends it to the oxygenator, to the pump, and back. And if you orient this right, it'll go right down the tricuspid valve. Veno-arterial, again, draws from the venous side, oxygenates the blood, and sends it to the arterial side, again, hopefully to provide adequate systemic perfusion. Most patients with adequate cannula size, we can flow 5 or 6 liters, which essentially should be good for any patient that we have. Despite in theory, the technology not having changed significantly since John Gibbon started all of this, as I mentioned, the dual lumen cannula is a significant improvement. We have patients, especially the lung transplant, pre and post lung transplant patients, who have these neck cannulas that walk around the unit. We have tried some ambulatory VA ECMO, although that makes me slightly more nervous. The hollow fiber oxygenators are an improvement over the silicone membrane oxygenator. One, they can last longer, they're less thrombogenic, they have a lower surface area, so they activate less platelets. They're a decreased pressure gradient, so There's less red blood cell trauma. The tubing is, we've switched to newer tubing, centrifugal pumps. Don't crimp the tubing, and additionally, these systems are very small and portable. Here's a diagram of sort of a smaller type system. You see the carts that we have that are about 10 times the size of the smallest system. But very simply, all you need is an oxygenator, a pump, and some tubing, and you're in business. So indications for respiratory failure. I'm not really going to read through this. I don't do a whole lot of respiratory therapy. One of my colleagues, Matt Hartwig, is really more sort of the respiratory failure Ecmo champion. But obviously the indications for respiratory failure in veno-venous Ecmo are hypoxia, hypercapnia, and then essentially any patient who is either pre or post lung transplant may qualify. But VV Ecmo allows for both low pressure and volume ventilation with a very low FiO2. Most patients on Ecmo are on 21%, so that the lungs can recover from acute lung injury. In terms of cardiac failure or shock, you look at this list of indications, and this is why we have a difficulty in studying and comparing patients who are on Ecmo. It's difficult to compare the patient who had a heart transplant 2 years ago who has primary graft dysfunction with a patient who has acute coronary syndrome or decompensated heart failure. But you do have to say that the number one reason for Ecmo is failure to wean from cardiopulmonary bypass. I'm not going to discuss that, but that is the number one reason. Then obviously these other causes. But Ecmo is a relatively quick and relatively easy way to stabilize the patients that we can make a decision. And you saw from the four examples that I gave that's what it did. It gave us time so that we could make a decision. One patient went to the operating room and had an aortic valve replacement, which is relatively rare for an Ecmo patient, I have to admit. We had multiple patients recover. If you walk through 3200 at any time, you'll see multiple patients on Ecmo, or not multiple, but usually at least one patient who's on Ecmo as hopefully a bridge to either mechanical circulatory support in the form of an LVAD or BiVAD support or transplantation. And again, the key when we think about these patients is that time means their kidney function, their liver function, and their neurologic function. And so sooner is better. There is some use of Ecmo in trauma. I won't spend a whole lot of time on this, but massive tracheobronchial injuries, inhalation injuries, drowning, and hypothermia. The Ecmo machine is an excellent way to warm a patient, and we haven't done that here for a long time, but I know we have. When you think about trauma patients, you have to worry about anticoagulation, but don't let the perfusionist fool you. You do not have to be on heparin to be on Ecmo. Especially veno-venous Ecmo. Having said that, if you don't put them on Ecmo, there can be significant consequences, but there are a number of times where we are unable to put people on heparin, and trauma would be one of those situations. But there are multiple reports of people having damage control laparotomies on Ecmo and things like that. So contraindications, this list actually was about 20 things long, but then I started to look through it and I thought, no, we put that person on Ecmo, we put that person on Ecmo, we put that person on Ecmo. So I took a bunch of them out. Now, age is not a contraindication to anything anymore. But, the 95-year-old who has had a big MI, maybe we wouldn't want to put on Ecmo. Disseminated malignancy, severe brain injury, aortic dissection, obviously, one, you don't want to propagate the dissection, and two, either by increasing their systemic perfusion and enlarging the tear or cannulating the false lumen of the aortic dissection. Sepsis, prolonged mechanical ventilation. I think really that's a contraindication because you have to have, for hopes of lung recovery, people who've been on the ventilator for a month are not likely to recover the lung function. And then futility. And I think, it's rare that we have cases that we think are futile, but I did get consulted from the SICU on a case. It was a young guy who had had a cervical fusion and suffered essentially a spinal cord injury. And so essentially, it's hard to tell, but it was in spinal shock. And they called me to see if I would evaluate him for ECMO. So I walked down, and they're actively coding the patients. And when they did compressions, he would move his left arm, but wouldn't move anything else. So he was essentially paraplegic, but he would move his left arm a little bit. When they stopped doing compressions, obviously he would do nothing. he was already in renal failure. So even us surgeons at times have some common sense about when we should do things and when we shouldn't. And we do have to at all times consider the likelihood of organ and end organ recovery. Again, patients who are in renal failure who are put on ECMO do not do well. I mean, it's essentially 100% mortality. So ECMO data, when I was putting this talk together, I was reviewing all the data, and I thought, this is going to be great. There's no data on ECMO. And then I thought, I've got to put a talk together. This is horrible. I've got no data. The difficulty with looking in terms of critically thinking and evidence-based medicine is if you're a pediatric patient, there's a lot of data actually on ECMO and the success and what works and what doesn't. If you are either a lung transplant or have some sort of primary lung disease, additionally, there's a lot of good data. But if you look at the patients who are put on ECMO for cardiogenic shock or have a cardiorespiratory collapse, there is not a lot of good data. It's mainly registry data and sort of single center studies and reports. And so there is not a whole lot of good organized data, and that's one of the things that we would like to improve here at Duke by creating an adult ECMO center to try and capture more data and become a little bit more scientific about what we do. What we do know from this is really from registry data, and this is from the 2013 Extracorporeal Life Support Organization summary. And if you look at all comers, survival if you went on ECMO for a respiratory, so most likely VV ECMO, your survival to decannulation was 64%. Your survival to discharge from the hospital was 55%. If you were put on ECMO for a cardiogenic cause, but not in a code, your decannulation was 55 and your survival to discharge was 39%, so not as good. If you underwent ECMO placement during a code, your survival was 37%, or excuse me, your likelihood of being removed from ECMO was 37% and survival to discharge was only 28%. Again, if you look at adults, which we consider 16 years and older, you can compare the difference in percent survival to discharge. And again, it changes depending on your diagnosis. Patients with sort of an acute fulminant myocarditis who likely would recover, their survival to discharge was 65%. But if you look at patients who underwent cardiac arrest, it was only 30%. This is fairly similar to our Duke data. This is somewhat incomplete, and we have relatively low numbers. But if you look at all comers, survival to decannulation was 63%, and survival to discharge was 49%. But you have to remember that we have a large lung transplant population. A lot of those patients, not a lot, but a number of these patients were put on ECMO either prior to or after their transplantation, and their survival is higher than somebody who was put on ECMO for a code. If you look at the elective urgent VA ECMO, so this would be patients who were in the CCU or in 3200 who had intractable VT or heart failure who needed to be put on ECMO. Their survival to decannulation was 62% and survival to discharge was 38%. And then patients who underwent ECMO placement during a code was 25%. Now again, these numbers there's very little to these numbers, and we're trying to mature this data. But these are pretty typical of the average. But that essentially is all the data I have, unfortunately. So complications. ECMO is a very simple thing that we do. It's relatively quick, but there are a significant number of serious complications. The first of which is bleeding, as demonstrated by three of the four cases I presented. Patients on ECMO are at risk for increased bleeding for multiple reasons. They're coagulopathic. One, unlike the pediatric population where their circuit is really small, they prime the circuit with a unit of blood. We have a large circuit that you would have to prime with multiple units of blood. So oftentimes they get diluted when they're first put on ECMO. And additionally, although the tubing is heparin bonded, the oxygenators are better and don't consume blood products as much, there's still a significant risk of coagulopathy. Obviously, as I said, anticoagulation is a big issue. The tubing is heparin bonded, but that really means nothing in terms of clot formation. We try and run the ACT in these patients between 160 and 180. We're trying to switch to actually PTT-based anticoagulation. But in a patient who is already coagulopathic for other reasons, or who has an open chest, this increases their risk of bleeding significantly. Neurologic complications is really truly the most devastating complication. Because of the configuration, veno-venous patients have a very low risk of stroke unless, of course, they have a PFO. But between 10 and 50% of patients put on VA ECMO have strokes, and some of these are minimal. It's difficult to tell. A lot of these patients probably have stroke during their initial code event and convert these with anticoagulation to a hemorrhagic stroke. But this is obviously a devastating complication. Additionally, patients who are kept on ECMO for a long period have a very high rate of critical care myopathy, and we have multiple examples of that. Vascular access complications. As I said, I keep saying it's relatively simple and relatively fast, but putting it's 19 French cannula in a patient's femoral artery while somebody's doing compressions can be very difficult. We've had the whole run of complications from dissections to putting cannulas through the back wall of the iliac artery, the iliac vein. I discussed this case, the heart transplant BK, where we did axillary cannulation, and we do that by sewing a access graft onto the axillary artery. And she had some bleeding, but it really wasn't that bad. But what she did have was that the tube graft that we'd sewn onto the axillary artery was compressing her axillary vein too. So she had arm swelling, then she had some bleeding. We had a patient recently on VA ECMO who had a brachial plexus injury, probably from hematoma from bleeding. And then, obviously it's site dependent. The first patient had a wound infection from his groin re-exploration when he was decannulated. Thromboembolism, again, clots can form in the machine at any point. We're very vigilant to monitor the cannulas and the pump to ensure that fibrin clots don't form. But sometimes you have to use judgment as to when to remove these or switch the pump out. Air embolism can occur. If you ever have a patient on ECMO, you have to realize that anything going into the venous system is going to immediately go to the arterial system. So, I've seen, you see in the ICU or in the operating room where we have a patient on ECMO, and, you watch the IV tubing and there are air bubbles just running in, and I think it's one of those things that you have to be a little bit more vigilant, not a little bit more, much more vigilant about, because those air bubbles are going to cross straight over through the filter of the lungs and go right to the arterial circulation. And I don't think we have a documented case of massive air embolism, but it could happen. Additionally, when you have additional ports to the ECMO circuit, such as for CVHD or plasmapheresis, it is another area for introduction of air. Heparin-induced thrombocytopenia is a significant problem in cardiology and cardiac surgery. And ECMO, obviously, we maintain these patients generally on heparin. We will maintain patients on bivalirudin, but we've had a number of patients with HIT. Infectious complications, they increase with the urgency of the procedure and emergency. You have two cannulas in the groin, which generally aren't necessarily the most, we call it a sterile procedure, but oftentimes, frankly, it's not, so we have to be very vigilant for infectious complications. And then for our patient population, one of the major issues with VA ECMO, where again you're drawing the blood out of the venous circulation and sending it back to the arterial circulation, is that in any patient who has decreased left ventricular function, the left ventricle is not going to empty. And if they have AI, like the first patient did, the left ventricle will dilate and cause both worsening LV function over time, but additionally stagnation of blood in the LV, and we have had patients with both thrombus in the LV and the RV because there was not enough blood transiting through. We had a patient relatively recently that we actually had to take back to the operating room and essentially clear the entire right ventricle of clot. But oftentimes to circumvent LV distension in a patient with either very poor LV function is not able to empty on its own, we will place an LV vent through the right superior pulmonary vein. So deployment. We know from both the pediatric data that improvement in efficiency and timing of deployment makes a difference in these patients. We have some data from other centers like Columbia that also supports this. So I'm not sure how many of you have been involved in ECMO deployment, but it's somewhat of a circus, I'll admit. So we've had a couple people, mainly Desiree Bonadonna, who's now our manager of the adult ECMO program, myself and Matt Hartwig, who've worked fairly hard on working on an adult ECMO deployment strategy, much like the pediatrics people have. And it's going to be relatively simple, and this is our first sort of step into improving our ECMO services. But we want to improve access and efficiency. It can happen essentially anywhere in the hospital, the emergency room, the CCU, the cath lab, EP, the MICU or the SICU. And we're starting with relatively simple things, any witnessed arrest or cardiogenic shock. And the way it's going to work, and this is just sort of the brief overview, Desiree has put in weeks of actually having the protocol. But basically what you would do is call the heart transplant surgeon on call. At this point it would be Carmelo or myself. And then after a brief discussion, you would call, if it's sort of approved, dial 115, and that would then alert the charge nurses from the respective ICUs, perfusion, the OR staff. We may or may not have cardiac anesthesiology, and I think it would eliminate some wasted time, because it always takes different people here at different times, but also I think in terms of, say, the cath lab or the CCU, it'll improve services, because after that's done, your job in the CCU is going to be to stabilize the patient and stabilize the patient only, because the 3,200 charge nurse and perfusion should come to the CCU with everything that we need, as opposed to having 5 people in the CCU running for different cannulas or running for drapes and things like that. We should have all this put together. This is really just this is just preliminary. Hopefully in the next month we'll actually start rolling out the deployment strategy. But in the meantime, you can always just page me directly. As I said before, one of us is always here. I mean, if it's not Carmelo, it's me, and we are essentially here all the time. And then Monty's coming on staff next year. And so literally, probably 24 hours a day, there will be one of us here. I think there's a reason why the 3 of us went into this. We actually like doing this stuff, as painful as it is, and we're always happy to discuss cases or help out in any way that we can. So future directions, we would like to, I think this ECMO deployment is our first step in establishing an adult ECMO center. There's some centers around the country like Michigan and Columbia that have already done this and have excellent programs going. But we would like to, for this region, become both a respiratory and sort of cardiogenic shock center, to the point that at some point we'll have teams that go out and cannulate patients and pick these patients up. We're not close to that, but I think that there's a need in our region and that we can fill that need. I think, looking at what little data we know about ECMO, most of which comes out of Michigan, frankly, that there's an excellent opportunity for clinical and basic science research, for critical care research. So if anybody ever has any interest in doing that, please contact one of us. And then I think the ultimate goal, as I think about it, is sort of to have a cardiogenic shock network similar to the ICC Express and to the RACE-AD, which is going to be the dissection network that we are starting to roll out for acute dissections. And I think that, as I said previously, time is of the essence, and patients who are in this region who go into cardiogenic shock should be at our hospital, and we should be treating them. And I think it should be a combination of the CCU, our advanced heart failure team, and cardiothoracic surgery. And in the coming months to years, I would like to continue to work on this. Again, sort of 2 main points. Time equals end organ function. No end organ function means there's nothing to do. And then ECMO should always be considered. Again, I don't think that you should call us for every patient that you see in cardiogenic shock, but you can. I'm happy to. I field phone calls all day, all night. But it is something that I think one of the problems that we have is that ECMO is thought of 18 hours into a patient's hospital stay. And I think that the sooner you call, the more success we will have. But also, the discussion between the multiple groups involved is always very useful. I'd like to thank multiple people. Desiree, who is, I think, has been our ECMO sort of manager or leader, has been on for about 6 months, is doing a fantastic job. Matt Hartwig is sort of the champion for the pulmonary failure, lung transplant side. Obviously, everybody in the CCU, our advanced heart failure service, and then we have a fantastic group of nurses and respiratory therapists and perfusionists in 3200 who take excellent care of this group of patients. Obviously, wouldn't be possible without them. So, thank you very much. Any questions?